Sir,
Sir,
I fully agree with sir. The same surgeon, when opens the abdomen with a longitudinal incision, it becomes a faster surgery than same surgeon opening it in a transphalangeal incision.
And access.
Second thing is you don't hope to get a good relaxation in such a patient. Of course. So that because that relaxation is always better. Secondly, any other procedure, you are more comfortable. And this, I am not an obstetrician, from whatever experience I has of anesthetizing patients, I believe. And sir, don't worry about a possible hernia post-operatively and create a problem on the table. See, so that is the issue. I know the surgeons are worried about hernia, incisional hernia, but that can be taken care of once the patient is saved.
See, more importantly, what I want to emphasize is, yes, be comfortable, do what you want to do. Many a times you have seen financial, they are very comfortable, but it all depends on, not everybody is you and you yourself. You think when you make a department protocol, it is not that, okay, I'll put a central line and central line is the choice as the protocol A. I have to think the weakest link in my department, my team, what he is comfortable doing it is what my protocol today is. So, and subsequently, the protocol can be tweaked and upgraded. What I want to say, when I say these are all the things, I'm just throwing questions, it does not mean that they are all gospel truth. It's just that it has come from our own experience that yes, like suppose if I'm doing a cesarean section in a patient with bilirubin of 16, INR of 4, elective cesarean section in a bilirubin of 16, INR of 4. I'll be happy if my surgeon takes a midline incision because this patient has coagulopathy, existing coagulopathy. And tomorrow she's going to bleed, possibility is there, she may come back for re-expiration. So it all depends on what situation you have, what medical problems you have, and what comorbidities you have. I'm just trying to put in several permutations, combinations just to throw light so that you don't go with one thing, I'll do only this. You have to have a flexi mind so that when given a choice, I can go for midline. When given a choice, I can go for financial. If given a choice, I'll go for repeat financial only. It all depends on you, but have an open mind so that things become easy, the algorithms are better, and manage. At the end of the day, cosmetic versus life-saving, cosmetic versus return to theatre is all important. So, in these cases,
sir, if we are suspecting injuries, and we are reopening, like GI injuries, ureteric or bladder, then it is always better to take midline.
Well, the other thing I wanted to add here for obstetricians, especially when we were doing our residency, when we used to do obstetric hysterectomy, we used to use a lot of suture materials and do the hysterectomy that way. What we used to notice even then, that the patient, when has entered coagulopathy or the consumption, a lot of these pedicles or the raw areas would bleed. So if you're in a center where you're doing a hysterectomy, and if you have the opportunity, use the vessel sealers. It'll close off the raw areas, prevent bleeding from happening, and DIC, etc., will not start bleeding from the edges which have sealed. And that, when it comes to hemostasis with your incision or the hysterectomy that you've done, is taken care of. So you can concentrate on other things.
I'll ask you one more question. How many of you have seen rectus sheath hematoma?
Sorry?
Rectus sheath hematoma.
Of course we've seen. Of course.
It will not happen with midline incision. I mean, what I mean to say is, because you're putting this thing, you're stretching the infraepigastric, this thing, retracting it, just sheared and it just retracts, it's not seen. So what I mean to say is, when you have coagulopathy, do least trauma, and yes, use vessel sealing and all those things are very, very important, very crucial, but you have an open mind to do the best for that patient. That is important. And stump bleeds are very notorious for controlling. It's very difficult to control stump bleeds. And worst scenarios, if you can't control hemostasis, just pack and come out. And so, like the packing is not to forget that old art of pack the abdomen with sterile gauze pieces, but see that you keep a count correctly, tie with one another, so that when you're removing at the end of 24 to 48 to 72 hours, you remove all the mouths pack. But all major hemorrhage can kill a patient, but you need to have the wherewithal and capacity and mechanism to control surgically, to control medically, and as an anesthetist to resuscitate appropriately with fluid, blood components, and have MTP in place, massive transfusion protocol in place, tranexamic acid, fibrinogen concentrate. I'll throw two more questions. How many of you have seen or a request from the patient that मुझे मेरे बहन का ब्लड चाहिए, मुझे मेरे भाई का ब्लड चाहिए, मुझे relatives का ब्लड चाहिए? Not very. We see in particular.
In planned operation, they are asking.
They are asking. In planned cases, they ask. So, what is your say? Would you want to give relatives blood? No. Yes. Why?
So, relative might have some hematological disorder.
Donor also may have a hematological disorder.
Autologous.
Yeah, as you rightly said, yes.
Autologous problems.
They have this graft versus host disease. Actually, thing can trigger graft versus host disease. So we don't encourage relatives' blood. And importantly, if at all somebody says insist on relatives' blood, then you take the blood, irradiate. Like when you're giving intrauterine blood transfusion therapy as a part of fetal transfusion, you irradiate the blood, maternal blood. So irradiate the blood and you can give. But importantly, relatives' blood is not encouraged. I'll ask one more question. Like this patient has atonic PPH. She is not a multi-gravida as was put on. Let us say she is a primary gravida. She is RH negative. She is RH negative. And you have given multiple random platelets and other things. Are you concerned about RH isoimmunization? Mic le lo.
After certain numbers of SDPs or platelets, we'll have to repeat the anti-RH.
So, other thing that you need to keep in mind is, if the fertility is preserved in a RH negative woman, where you have given multiple random donor platelets, it is better that you give anti-D injection within 72 hours, so that the subsequent pregnancy is, the RH immunization does not occur. It's a level 3 indication, but still it is worth giving, especially because random platelets are pooled platelets, multiple donors, single donor platelets from single donor. So those are the few things that you need to know about blood and blood components. So in a nutshell, when you have massive hemorrhage, you need to have uterotonics management clearly, fluid management, endpoints of fluid resuscitation. Do not over-dilute, do not hemodilute. As Madam said earlier, transfusion trigger should be 7 grams and above. Do not allow hemoglobin to fall to critical level. The critical HB in a pregnant patient is 5.2 grams. What does it mean? That means if the hemoglobin drops to less than 5.2 grams, anaerobic metabolism sets in. Lactate production increases. So do not allow hemoglobin to fall to less than 5.2 grams. Importantly, most of the women are anemic. So a good obstetrician will not allow her patient to come with hemoglobin less than 11 grams till delivery. That is very, very, so antenatal screening for anemia, treatment of anemia, even if she comes at 8 months of pregnancy, if the hemoglobin is 9 grams, give enough iron, total iron therapy, bring the hemoglobin to at least 11 grams, because a term patient, regular ANCs, coming with anemia is unacceptable antenatal care. So you need to be very, very, this thing. And importantly, if the mother delivers without much of, say, hemoglobin is 8 grams or 9 grams, give a total correction of anemia before discharge. This also is very important. So those are few things which are very important. So management of hemorrhage includes uterotonics, fluids, blood, and most importantly, post-resuscitation care. A word about post-resuscitation care. How would you, like this patient develops massive abdominal distension post-operatively. What do you think? You are managing the ICU.
Acute dilatation of stomach, peritonitis, you might have taken bowels in the stitch.
Bowel injury, RLS, anything else which is directly related to your resuscitation, because you are given 6 liters of fluid, 6 liters of fluid you are given, because blood has arrived late. Hypokalemia. See, overzealous fluid resuscitation will cause omental edema, small bowel edema, and will cause abdominal compartment syndrome. So, again, there is another reason why you should avoid overzealous crystalloid resuscitation. Because as I said, crystalloid does not stay in intravascular compartment. Whichever balance salt solution, after 30 minutes, they just go either in the urine or it can get absorbed in the third space. So you have to remember that excessive fluids, excessive crystalloids will cause small bowel edema, large bowel edema, and omental edema, which can cause abdominal compartment syndrome. So you need to, yes, other causes like hypokalemia, bowel involvement, peritonitis, injury to bowel, all those things are also important, but from our side, this is one of the preventable cause. Other important cause, once the coagulopathy is controlled, all these patients have ERAS uniformly, universally. Even if it's a peripartum obstetric hysterectomy or peripartum hysterectomy, let the patient sit and walk on the zero post-op day, on the first post-op day, and minimize PPCs, post-operative pulmonary complications, minimize DVTs. And importantly, it will promote your bowel movement also, and put these patients on low molecular weight heparin for at least a week. Once the coagulopathy is under control, it's very, very important. So post-operative ICU management is also very important. Now, she comes to you after 6 months with little fatigue and weakness. 3 months के बाद.
HIV.
Blood investigation, HIV.
HIV, yes. Anything else? She's a little fatigued, she feels little sleepy, little groggy, gets tired very easily.
Sheehan syndrome, because
Sheehan syndrome. So, keep this patient under your radar for 6 months. Keep these patients who have had any type of shock, cardiogenic shock, septic shock, hemorrhagic shock, whatever shock, especially hemorrhagic shock, 6 months. Because at the end of 2 to 3 months, proactively screen for Sheehan syndrome.
Fortunately, we have one preemptive sign to find out whether the woman is going into Sheehan's, and that is failure of lactation. If the woman fails to lactate in the first 7 days, be careful that woman is going to have pan-pituitary failure.
Yes. So, TSH is the first to raise, FT3, FT4 and TSH screening, and viral profile at the end of 3 months, and repeat viral profile at the end of 6 months. So, at the end of 8 months, if she becomes HIV or HBsAg positive, she will not sue you, because sometimes they may blame the primary surgeon, she must have acquired somewhere else. So, it is very important that these patients are followed up on short-term basis, on long-term basis, because transfusion transmitted sepsis is most common with platelet transfusion. Subsequently, PRBC. So, remember, blood is a fluid organ. Too much of blood will cause tacho and trally. Too little of blood will cause coagulopathy or inappropriate measures. And too late of blood also is going to harm the patient. So too much, too little, too late are eternal perils we need to avoid. So use blood judiciously. It's a fluid organ, and you need to have a patient blood management system in your town, in your hospital, so that in an event of this thing, everything has a smooth sail, and we can jointly do good thing for our women. And bottom line, no mother with hemorrhage should die in the current era. Thank
sir,
you.
Hypotensive resuscitation, that term, which is same as what you described, or it is something different?
It's same.
It's same. No?
Permissive hypotension. Permissive hypotension.
Sir, at what level of platelets? At what level of platelets you would not prefer regional anesthesia? Or would your anesthetist ask for the platelet report level before giving spinal?
See, the thing is, it is just not one single value of platelet. We'll discuss this in the panel discussion.
Okay.
We'll discuss the panel discussion. But to answer your question, I'm comfortable with a trend of platelet count. I would like to see the patient rather than a platelet report. And I will be giving comfortable spinal in a platelet count of 55,000. I will be uncomfortable in giving a patient spinal with a platelet count of 1 lakh also. It depends on the clinical situation. So don't go by the report, go by the clinical situation. We'll discuss more on this in the panel discussion.
And keeping drain inside while you are dealing with a case of coagulopathy. Drain has to be
put. A tube drain in the abdomen. Do not put suction drain in the abdominal cavity. If you are putting suction drain like that Romson say, the momentum will block all the orifices, nothing will come out. So one tube drain in the pouch of Douglas or paracolic gutter and one subcutaneous drain and mattress sutures. Don't take continuous sutures because mattress sutures, you are giving windows for the blood to come out because this coagulopathy is still there. If you are taking continuous suture, seromas and hematomas will form, which can be a source of secondary surgical site infections. Most importantly, I asked repeatedly, or kuch. Antibiotic was not given. Prophylactic antibiotic has to be given. Generally, a broad spectrum, whatever your protocol, cefuroxime or ceftriaxone sodium or cefotoxime, but see that prophylactic antibiotic is given stat at the time of induction, and if the surgery gets prolonged beyond 4 hours, you repeat one more dose. But in case of massive transfusion, you repeat within 2 hours. You don't wait for 4 hours. Okay? So with this, we'll quickly move to the next.
Any experience with the PPH cannula in your unit? Atonic PPH, to control atonic PPH?
Yeah, Paniker's cannula. Yes. See, the surgical methods are very good. The Paniker's cannula which is there, in fact, the condom catheter is out. It's no longer recommended. Bakri balloon is still being used, but Paniker's cannula is, I am told, is very helpful. Our unit, they have not used it. But there are some vascular clamps, we are all well versed with those things, but importantly, Paniker's cannula is nothing but you just insert the cannula intrauterine and apply a negative pressure of 600 millimeters of mercury. The uterine walls collapse and coalesce, and it acts like a tampon, negative suction. But our unit has no personal experience. But Dr. Paili has a lot of experience. So we'll quickly, thank you very much, madam.
So thank you all participants.
Need 6 more, yeah.
Yeah, we're moving for third case scenario. So maybe we are happy with the dealing with the hemorrhagic shock, and now the many more in black box, I can say. So again, delegates who really wanted to volunteer, one obstetrician I need from the audience, and nurse is there already. Should I call upon by name, or do you want to volunteer?
So she comes with that.
So from anesthesia side, Dr. Parag want to volunteer. Dr. Bhumi,
starting stage.
Anesthesiologist want to volunteer the case. Dr. Styen, are you here? Yes. So you are the leading obstetrician for the scenario third scenario. And Dr. Sagar Bhavsar. Dr. Sagar Bhavsar. Dr. Neha. Again, this is for the participants. Be leader, be clear in your statements. Whatever you want to do, do it in real way. Whatever you need, call for help.
Ma'am, you are doing?
Again, it is closed, sir. Enter password. We're happy with only this is a different. What we are dealing with is 4.
Second post of day.
No, this one, 37. So we are going over here.
Case scenario 4.
Yeah.
Okay.
So scenario is.
Hello.
37-year-old lady with the 34 weeks of pregnancy. 37-year-old lady comes with 34 weeks of pregnancy and complaining of shortness of breath. Complaining of shortness of breath. 34 weeks of amenorrhea.
She's not in labor.
Whatever you are asking, you ask in the mic so we can hear what you really want to diagnose, what you want to know from the history.
Is it working?
Yeah, it's all. She comes in breathlessness. In emergency track.
In emergency.
34 weeks. This lady, hello. This lady is a 37-year-old lady, 34-week gestation, comes to emergency room of your hospital with severe breathlessness. The primary nurse and obstetrician.
Nurse.
Hudson mask.
Yes.
You can ask the history. You can take the history.
આપી દો. હું તો પેશન્ટ.
સર માથું બહુ દુખે છે 2 દિવસથી ને કોઈ વાર ધબકારા વધી શ્વાસ લેવામાં તકલીફ પડતી હોય એવું લાગતું છે. ધબકારા બી કોક વાર વધી જતા છે. ના સર એવું કંઈ નથી. નહીં એવું બી કંઈ નહીં. શ્વાસ લેવામાં તકલીફ પડે. રાતના ઊંઘ બી નહીં આવે કોઈ વાર તો. સર કોઈ વાર રાતના ઊંઘ બી નથી આવતી. દમ ચડી જાય, બેઠા થઈ જવું પડે.
પલ્સ ઓક્સીમીટર લાવો સિસ્ટર, કાઇન્ડલી આપી દો.
એક્સરે નથી.
ઓક્સિજન
માઇક એ સંભળાતો નથી. માઇક ઓન કરો યાર.
Hello. Okay, so I just examined the patient and she is having breathlessness. On the auscultation, I can feel the cramps. So can we call upon anesthetists on the call?
Yes, sir. How we have to proceed? We have to do in the anesthesia.
સાહેબ બહુ દમ ચડે છે.
She just came for the ANC checkup and otherwise my side is everything is okay except I can feel there is a cramps.
Yes. I want cardiologist reference, X-ray, chest, echo, and whole blood count, CBC, SGPT, creatinine, and I want it to get checked by cardiologist and chest physician.
We would like to first give oxygen by Hudson mask. Let's find the cause of why she is having hypoxia. And is she having a history of preeclampsia or something?
બહુ બેચેની લાગે છે. કંઈ કરો ને શ્વાસ બી તકલીફ થતી છે.
Oxygen we have put.
Her BP is right now 150/100. Previously she was having normal blood pressure. Nowadays now I can see it's 150/100. So maybe she is in the stage of preeclampsia.
Okay.
So can we do the 2D echo in this patient?
સર મને કંઈ જાનનો ખતરો તો નથી ને?
We can give labetalol to control her heart rate and blood pressure.
Okay.
Is she having
મને જરાક નિફેડિપિન આપજો પહેલા
Nifedipine.
ફર્સ્ટ.
સર બેબીની મૂવમેન્ટ બી થોડીક ઓછી થઈ હોય એવું લાગતું છે.
બેન જૂની કોઈ બીમારી છે તમને હૃદયની કે
ના એવું હમણાંથી જ થયું છે છેલ્લા 2-4 દિવસથી.
બરાબર. અને દમ અસ્થમા એવી કોઈ તકલીફ છે?
નહીં એવું તો કંઈ નથી. સુવામાં જ તકલીફ પડે છે.
સુવામાં રાતે તકલીફ પડે
ને
છે.
ચક્કર આવે થોડા થોડા.
પહેલા તમે દવા ગળી લો નિફેડિપિન. નેક્સ્ટ વિલ સ્ટાર્ટ વિથ ધ મેક્સેલ્ફ. તો આપણે
Sir, she is going in ventricular tachycardia. She is going in ventricular tachycardia. We need to. Do we have defibrillator? Can you please?
We check the pulse. If pulse is not there, we have to give the DC shock first.
Please
And I
put
have to
one
intubate
18
also.
gauge cannula, please.
Can you have AED please? Because she is in the. It's a fibrillation. So can we start the AED?
There is no pulse. Yes, we all clear. Please give me the laryngoscope and ET tube. Sir.
Adrenaline ભર્યું છે?
Yes, give me laryngoscope and ET tube.
Set the joule at 200.
We are giving 2 milligram of midas as she is awake.
Please keep fast.
Clear.
Yeah, shock given.
Please continue with the CPR. I am putting the tube. Please give another laryngoscope.
Mask. Intubation.
Endotracheal tube.
Here is the tube. Kindly give the tube. Can you please push?
2 minutes are over.
બીજી ગ્રીન ફૂલ અહીંયા લઈ લો.
Okay, in.
Prepare atropine and
Let's start the ventilator.
second time stop. DC stop.
Please give adrenaline.
મેડમ આપ્યું.
Adrenaline.
સેકન્ડ રિપીટ કરવું છે?
Yes.
200. चलो.
Please give soda bicarb also 50 ml. Continue with the CPR, please. Can you please give noradrenaline infusion?
Adrenaline, you fast.
Give another adrenaline. Ventilator पर છે.
No, ma'am.
Please give one more adrenaline.
3 minutes.
You can see they have shocked the rhythm already, but still the normal rhythm has not come up. So they are continuing the ACLS process.
Please continue. with the
Advanced
CPR.
cardiopulmonary life support.
Adrenaline 3 times given.
Can you please take out the baby?
In this condition?
This position I cannot remove the baby.
Yes.
ચલો સર.
I don't want to be a metal or moderator.
We are little late, but please do it.
Please call the pediatrician immediately.
Fast, yes.
Please continue with the CPR.
સિસ્ટર જલ્દી ખેંચો.
जल्दी सिस्टर मदद कर.
Please give adrenaline 1%.
Support it.
Perimotum cesarean section.
Cut it. Give to inhibitor. કાઢે. જરા જોઈ લેજો બચ્ચો.
Should I come here? If you are.
So atonic PPH is there.
Oxytocin, Garbaprost.
Atonic PPH.
rhythm is there.
जल्दी close.
बस सिस्टर.
चलो fast.
Please check the
There is
carotid
atonic
pulse.
PPH.
Hemostasis achieved.
How is the baby now?
It's normal rhythm.
Baby is limp requiring intubation.
શું સાહેબ આવ્યું કે નહીં patient?
There is no pulse. Please give AVD.
Baby is
Pediatrician
defib fast,
Okay,
defib.
wait. There is a sinus rhythm.
atonic PPH is there.
Okay.
मैं तो close.
It's bleeding like hell. Come on.
There is a normal sinus rhythm, sir.
Hello.
Atonic PPH is there.
बंद करा दीजिए.
Oxygen is. Please increase the dose of noradrenaline.
There is atonic PPH.
Just doing the
Norad and
compression.
adrenaline.
ઓક્સિટોસિન બીજા 3 નાખી દો. પિટોસિન 3
Aortic
નાખી.
compression करो. I do aortic compression.
PPH is better now.
Adrenaline.
But again, patient has gone into asystole.
Adrenaline.
Adrenaline. Give adrenaline.
Sister adrenaline.
Please start infusion, adrenaline infusion at 4 ml.
अरे नॉरेड चालू करो.
ચાલુ છે.
કેવું છે યુટ્રસ કેવું છે?
Fine. Now better.
I'm continuing with the CPR.
Blood જરૂર.
Come on, call. Where is the blood bank? Call blood bank people.
NSR.
સિસ્ટર બીટી
Ask for fast blood.
Sanitizer.
Ask for blood fast.
It is MTP1 444.
બીટીની કન્સેન્ટ લઈ લેજો, હાઈ રિસ્ક કન્સેન્ટ લઈ લેજો. સિસ્ટર પેશન્ટના રિલેટિવને એક્સપ્લેન કરી દેવો બધું.
Now PPH is better. Good.
Patient presented with supraventricular tachycardia, a shockable type of rhythm.
Aortic compression relieve કરું. I relieve. Aortic compression, uterus is well contracted. No PP.
ठीक है, कोई बात नहीं.
Little bit is there.
ठीक है.
Okay.
Good job.
Please continue.
PCV
Norad,
આવી ગયું છે,
dopamine and
sister?
adrenaline.
હા લાવ આપી દો.
30 ml.
પીટી માટે હું ચડાવવાનું છે.
It's okay.
છે નહીં.
Make it 90%.
Blood has come.
હા yes, start it now.
Start PCV.
Hemoglobin is 12 grams. Hemoglobin is 12 grams.
12 grams.
Maybe it's hemo concentration.
Heart
PCV
also.
push કરું.
You can feel the carotids.
બંને હાથથી પુશ કરો ફાસ્ટ. PCV એક
સિસ્ટર
સાઈડ.
હોય તમે એક થાળી પુશ
First
કરો, હું
FFP,
આમાંથી
first.
લઈને પુશ કરું છું.
ફર્સ્ટ FFP ચાલુ કરો.
FAP PC start करो.
ठीक है.
એક સાઈડથી FFP ચાલુ કરો સિસ્ટર, પેલે બાજુ
Sign
જઈને.
out. Do the signing out.
બંધ કરી દે.
I'm closing.
Closing the abdomen.
Iron of support. So we have to patient.
Yes, we will shift the patient.
She is on the iron of support. So we have to shift the patient to the ICU for iron of support and ventilatory support.
From our side, the uterus is well contracted. There is no bleeding right now. So
Hemostasis
we are just closing the abdomen.
abdomen. Yes sir.
I would like to do some post-operative investigations. CBC, serum electrolytes, ABG, and 2D echo and echocardiogram and one chest X-ray. And
Electrolytes.
electrolytes
Shift
done.
to ICU immediately. Shift to ICU immediately.
કાઢી લો.
Thank you. Good job. તમે થોડું ડ્રેમેટાઇઝ કરવાનું કહો. પછી જો ટાઈમ પડે તો પૂછીએ આપણે કીધું તો કરીએ. થેન્ક યુ. ગુડ જોબ.
બરાબર.
એકદમ ફર્સ્ટ ક્લાસ.
Sterling.
I think the patient survived the cardiac arrest. Quite. So what do you think that you have done good? Can we have this obstetrician? Dr. Avi. Satya. What do you think that you have done good?
When we saw the patient first, vein flow, what? So we have started the treatment on right time. Basically, we diagnosed the cause and the anesthetists were on the line. So we got the support from anesthetists. That is more important on behalf of obstetrician because it's very difficult to manage this kind of case alone.
So your anesthetists took a little time to come and patients was saturating at 89%. could we have put 15 liters of oxygen? She was still breathing spontaneously.
Saturation was?
89%.
We have to start with the nasal oxygen by the time, and if you feel that mask, bag and mask, we can start.
So the thing is, again, I want to emphasize that nasal oxygen, please come over that term of nasal oxygen. Nasal oxygen gives just 30 to 35% of FiO2. What we breathe is 20.78% of oxygen, and what nasal oxygen gives is 35% of oxygen. When the patient is coming with extreme breathlessness, giddiness, and SATs of 89%, straight away go for ATLS, ACLS protocol. 15 liters of oxygen with non-rebreathing air mask. Give highest possible FiO2. And if you have anesthetist, you can directly put Bain circuit so that you can give 100% FiO2. But at least till the anesthetist comes, give 15% oxygen. If you don't have NRBM, then yes, you can definitely put nasal oxygen. Yeah. But at least give maximal FiO2. Anything else when the patient is having continuous giddiness, reeling sensation, head up tilt. Always little propped up position, gravid patient, you can always ask for head up tilt because we don't know, it's a heart failure. You see, you have diagnosed as crepitations. So one good thing, congratulate him because he has calculated. I have hardly seen an obstetrician with a stethoscope. It was good to see a stethoscope around his neck. So he has escalated heart failure, but you could have put the patient a little more propped up, oxygen. And importantly, at that moment of time, BP of 90/60. Anything else that you could have done?
Investigation.
Management-wise, clinical management.
Antibiotics.
Position, yes.
Left lateral positions given.
Left lateral position or 15 degree. Head up tilt with left lateral. Very, very essential. PACR square. Preload, afterload, contractility, rate, rhythm. So you need to you maintain the preload. So put a head up tilt and ask her to lie down laterally so that you can offload the IVC and aorta. Left lateral tilt. Yes. And wide bore cannula is already well put. So when you came into picture, what did you feel like?
The patient was in the breathlessness state and on the she's on the VTX stage, no pulse. So I found that patient is drowsy and in the VTX. So I started giving DC shocks of 200 joules 3 times, right, and intubate the patient and ask the surgeon to remove the baby as fast as possible.
Exactly.
And they did very well. And we started the inotropic support with noradrenaline and dobutamine. So I clinically judged that patient might have some cardiac problem also. So and then we continuously giving the CPR during the surgery and pre of the surgery.
So basically identification of problem and early shock. So whenever you have a shockable rhythm, there are 2 shockable rhythms, VT and VF. This patient went into VT.
Pulseless VT.
Pulseless VT. So it's a shockable rhythm and shock was delivered. But if you see the video, the CPR was started little late. So shock was not very effective. The patient went into ventricular fibrillation. Ventricular fibrillation. But in all this milieu, 4 of you were there. Anybody who was who was the master of the ship, captain of the ship?
Anesthetist.
There should be one captain. So what is the job of captain?
He has to communicate the team and guide the team properly.
The team. And timekeeping. Very, very essential. In fact, nobody was doing timekeeping and I was saying 3 minutes, 2 minutes, because I was just trying to push that concept of timekeeping is very essential, because what you have is in the event of cardiac arrest, time is critical. time is crucial, time is everything. Like it could be a septic shock, as I said, 1 hour of delay in antibiotic is going to increase the mortality by 10%. 1 minute of delay in BLS is going to increase the incidence of permanent vegetative state by almost 30%. So that you need to remember. So 1 minute delay of CPR is going to increase the incidence of hypoxic brain injury by almost 30%. So you need to be very effective BLS.
Very fast.
What was one grossly striking thing that was missing during BLS? Anybody? Anything from the audience? BLS. They were giving BLS first. CPR was started a little late, but anyway, they gave a shock. They found shock rhythm and they gave a shock. That was also part of BLS.
I saw that.
Yeah, shock.
We give shock.
Anything else that could have, that was very, very crucial. Left uterine tilt versus left uterine displacement. Which one you want to? Displacement. So there is, why not tilt? See, CPR is not effective when the mother is tilted to 30 degrees. Okay? The tilt that is required for a normal cesarean section after spinal, we give 15 degrees tilt is enough. But in CPR, the tilt is 30 degrees. When you're tilting the mother by 30 degrees, you can't give the chest compression effectively. The efficacy of chest compression is dropped to 62% only. Okay? So, always supine position and manual left uterine displacement. So, BLS in pregnancy differs from BLS in non-pregnancy by same 30:2 ratio, chest compression, push hard, push fast, but in addition, MLUD, manual left uterine displacement, is a part of BLS in pregnancy. Remember that. Okay? That is very important. And this was not done, and probably that was the reason that the mother could not be revived for late. Okay? So, manual left uterine displacement, shock was given, adrenaline was given. Again, closed loop communication was lacking. Give adrenaline. Whom? Who? So, okay. So, as I said, in the event of crisis or even regularly, address the people by their name. Okay? I'll just go back to my own name, Pramila. Sister Pramila, please load 1 ampule of adrenaline, 1 milligram, push intravenously, and run 30 ml or 40 ml of saline, because adrenaline has to reach myocardium. Okay? So it is very important that you rush fluid after that and raise the hand so that it helps, the gravity helps in making the drug reach the myocardium. And importantly, can I take a venous access in the saphenous vein of the lower leg?
No.
Exactly. So always obtain venous access supra-diaphragmatic, because we don't want aortocaval compression to hinder the drug reaching from the myocardium. Very important. So MLUD, venous access above the diaphragm level, is very important. Push hard, push fast. The sternal, I think we have a BLS mannequin, we'll do the practice later on. But it is very essential that, I think if somebody can perform BLS, anybody, any volunteer? We can, that BLS mannequin. So, if you see, just palpate the xiphisternum, palpate the xiphisternum, and mid-sternal region, 2 inch above the xiphisternum, put the dominant hand, the thenar eminence of the dominant hand, clasp with the opposite hand, and push hard, push fast. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12 and 13 and 14 and 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. So after 30 chest compressions, give 2 breaths. But if you are in the periphery, then continue chest compressions. Calls, compression only life support. That was our ISA guidelines, okay? So compression only life support guidelines is what we follow in case of out of hospital cardiac arrest. But in hospital cardiac arrest, 30 chest compression, 2 breaths, and keep doing it. And simultaneously, the patient has to be taken from BLS to ACLS within 1 minute. BLS to ACLS stage has to be reached within 1 minute for good cardio-cerebral resuscitation. I don't want cardiopulmonary resuscitation. I want cardio-cerebral resuscitation. And once the cardio-cerebral resuscitation is achieved, I want CPCSR. Anybody can know what is CPCSR? Cardiopulmonary cerebral splanchnic resuscitation. Because patients who come out of acute episode of cardiac arrest, you do a wonderful job, but some of your colleagues may give 10 ampules of adrenaline, 5 ampules of noradrenaline, intense vasoactive thing will cause splanchnic ischemia. And bowel ischemia will cause bowel ulcerations, small bowel ulcerations, portal circulation, and all the bowel gut microbes enter into the portal circulation, then become systemic sepsis. The mother will die after 2 weeks with multi-organ failure. Okay? So, initially CPR, CCR, CPCR, CPCSR. That is post-ICU resuscitation care that we can discuss. But more importantly, when you're starting BLS along with chest compression, when Dr. Tarun was doing chest compression, importantly somebody should give MLUD, manual left uterine displacement. I'll project my slide, but AOA has given 3 new terminologies during maternal cardiac arrest. One is 3 Fs: focus, first, and fast. Or first, focus, and fast. First is recognition of cardiac arrest and start immediate CAB. Okay? Fast. Focus the A, B, C, D, E, UPS. What has led to the cause? A, B, C, D, E, UPS. Anaphylaxis / anesthetic, bleeding, cardiac causes, drugs. E is hypertension, embolism. U is uterine causes. P is pulmonary embolism, and S is sepsis. So just as the captain of the ship should have in mind, is it A, B, C, D, an appropriate targeted pathway can be activated. Okay? So A, B, C, D, UPS, that is first, focus, and fast. Fast is if you do not achieve reversal of spontaneous circulation within 4 minutes, do a perimortem cesarean section. So how do you transfer this patient to theatre? Suppose, let us say this patient has come to ER and patient has collapsed and you are doing CPR. Now, how would you transfer this patient to theatre for doing perimortem cesarean delivery?
You should continue with the CPR.
Smart audience. So there is no need to transfer the mother to theatre. Do the resuscitative hysterotomy at the site of cardiac arrest only. Because if you transfer this patient on the trolley, on the bed, you are losing time on chest compression, which is very vital. As I said, 1 minute delay in chest compression is going to increase the incidence of hypoxic brain injury by 30%. Okay? And 0 minute wastage of time, and you give instant CPR, 57% of women with good Apgars in the baby will recover with your good resuscitation. That is the survival. So 57% chances of making her good are very, very high. So you should not waste any time. So BLS to ACLS less than 1 minute, ACLS to ROSC ASAP, but if you cannot achieve ROSC, that is reversal of spontaneous circulation within 4 minutes, shift or do a resuscitative hysterotomy. Again, initially the old term was perimortem cesarean delivery. That we have modified to RUI. I mean, it was modified to resuscitative hysterotomy because you are just delivering the child or the fetus to and lift the uterus from the aorta and vena cava so that you can improve the preload. And post-delivery, uterine contraction happens, and the autotransfusion will help in reversal of spontaneous circulation. But how many times, or rather I would say, how many of you have experienced or done perimortem cesarean delivery? None. We have done 12 in last 27 years, 12 cases. But believe me, each was a blessing, each was a learning, new learning. And some of the points that we have incorporated are not there even in European guidelines, not there even in American Heart Association guidelines, AHA guidelines. So one of the things that is very important is the resuscitative hysterectomy terminology we have modified to RUI, resuscitative uterine intervention, because many times they end up with peripartum hysterectomy also, because the uterus is flabby. Many times they end up with atonic PPH and they need B-Lynch. In this patient, the mother developed atonic PPH, sir. So how do you manage atonic PPH?
First stop PPH, uterine compression, then aortic compression. If not deadly, then uterine artery ligation.
Then in this patient atonic PPH, no? Ye patient.
We do the same thing here, sir.
Pharmacological management.
Yes.
Sir, we give
Nutrotonics drugs also.
Oxytocin in
patient
cautious dose.
Oxytocin was given and patient became asystolic again. So if you look at the causes of A, B, C, D, E, UPS, B, bleeding, then S, sepsis, E, embolism, eclampsia, embolism. At least there are 6 causes that has a propensity to cause atonic PPH, which can cause cardiac arrest. And post ROSC, it's a depressed and suppressed myocardium. It's a stunned myocardium. And even oxytocin 3 units intravenous bolus in this post ROSC is like giving a death warrant again. So do not use, or rather I would say use uterotonic agents very, very judiciously. So the communication from the anesthetist is, patient, we have just achieved ROSC, patient is atonic PPH, would you mind doing compression sutures? Rather than giving one more pharmacological this thing. So go for compression sutures. You can go for carboprost, because this patient, we don't know what is the cause, but at least go for the medication which has least effect on the myocardium. So misoprost is a better drug, or carboprost is a better drug, or even methyl ergometrin can be used, provided there is no underlying this thing. But oxytocin should be very judiciously used.
Ergometrin, sir, it should be avoided, sir.
In this event of post-atonic PPH, it has to be avoided, but when given a choice, but use judiciously. Go for surgical methods of surgical methods are better, but simultaneously the judgment should prevail, because if you are giving again rapidly 40 units of oxytocin like you do and run 125 ml per hour, it's going to cause rearrest. So prevention of rearrest is a very, very important. So decision to deliver at 4th minute and 5th minute delivery is very, very vital. Now let us say you don't deliver the patient. What will happen if you don't deliver?
Too late.
We are not bothered about fetus. We are doing everything for the mother's sake.
To save the mother, we have to deliver.
I was conducting this workshop in Mumbai about, I think, 2 months back, April. And one of those very, very upmarket area. And obstetrician said, "मैं नहीं करूँगा. First revive the heart." And this was the scenario. You first revive the patient, then I'll do deliver. I don't know deliver.
That's what I said, sir. Because nowadays we are worried for maternal mortality.
Yeah.
If anything happens, it will come to us.
Yes.
So,
1 second. Let us hear him.
So first, suppose to revive the patient first, then we should deliver. But suppose this kind of circumstances very rarely we can encounter. But what we feel that better to revive the patient than to deliver.
To save
So
the
how
mother.
many, see, sir feels better to revive the patient and then deliver. How many of you agree with him?
We should treat the cause. And
Technically, and from a humanity or the doctor's point of view, the patient should undergo peripartum.
It is not humanity's sake. It is a part of ACLS guideline.
ACLS guideline.
So,
ACS guidelines.
I know, medical legal. Medical legal. So I'll tell you one thing. Like manual left uterine displacement is part of BLS. Not doing MLUD in a pregnant patient, gestational age more than 22 weeks, that's one suprapubic or umbilical level, it is not giving proper care. Okay? So not doing perimortem cesarean delivery or resuscitative hysterotomy or resuscitative uterine intervention in a pregnant woman is negligence. It's a part of ACLS. So tomorrow, I'll give you two scenarios. One scenario, let us say mother has not been revived and you have not done resuscitative hysterotomy. And the smart attendant and the smart judge may sue the entire team for not doing perimortem because that's a part of resuscitation protocol. And they feel that it's a negligence on the part of the team of not doing. So that is ACLS guideline. So failing to do cesarean, delivery, resuscitative hysterotomy is a negligence. So now second scenario, you have done perimortem cesarean delivery, if not 4 minutes, but 6 minutes or 7 minutes, something has happened, but mother is not revived. You will be safe. You will be safe from the court of law because you have done the best interest of patient, given the circumstances, 4 minutes have become 7 minutes, 10 minutes, doesn't matter. But at least you have attempted to save the life. So but if you have not done anything, it will be considered as a failure of giving due diligence to the mother.
So better not to become obstetrician because if something happens, the government people will catch hold of us. If something not happens, then people will catch hold of us. So the dilemma is always between.
I know. See, it's a tricky situation, and like as I said, last 27 years we had only 12 cases, but the 12 cases has given us humongous learnings. But luckily, at least we are updated right from day one, and we are very aggressive of PMCDs in our hospital. But this is the scenario that one of the take-home should be, do not hesitate to deliver her. And if you have an obstetric person in the team, best thing is that person does it. So code blue has to be announced. The code blue in obstetric setup should include a neonatologist, also should include an obstetrician also. In addition, the backup multidisciplinary team because we don't know what's going to ensue, because we don't know the cause. It could be embolism, it could be something else. Patient has to be shifted to cath lab. So code blue in pregnant women should include a neonatologist also and obstetrician also. And obstetrician has to be well versed with the protocol of resuscitative hysterotomy. Again, a very beautiful low-cost mannequin is available. I'll send the reference to the ops group. It costs 5,000 rupees where you can practice perimortem cesarean delivery. You can create that thing, like in this is a high-cost, high-end simulation where you can run all these things, but otherwise also you can practice these things so that what the patient needs is just vertical incision, deliver the child, put green armitage, lift the uterus away from the thing and deliver and wait for and continuous CPR. A continuous CPR is very, very important. So, yes, sir. Mike Didi, yes.
So question will come to the consent and counseling. And if you are saving a life, there is no need of consent.
There is no need of
because
consent.
If you are wasting time in taking consent, patient will die. That is one. Second thing about counseling, there is no scope for the counseling. So the thing is, whoever are present in operation theatre, at least anesthetist should be there. And time should not be wasted by the anesthetist because most of the times what happens that before you call anesthetist, patient will not survive. So provided anesthetist is there, you are there, relatives are okay. Okay in the sense that whatever you have done, they are going to fight out. So those type of relatives are not favorable for us. But considering technically, fine. Perimortem hysterotomy. Hysterotomy is the correct word because you are not doing a lower segment cesarean section. You are putting a vertical incision on the uterus and you are delivering baby very fast. Even anesthesia, local vocal may not be there. You just put an incision. I don't think there is anesthesia also required. Patient is not in a position.
Patient already is unconscious.
Patient is. So in that condition, the thing is, somebody from your OT will go outside and will inform them that we are going to do this, irrespective of the fact that whether they give consent or not.
Absolutely. So the take-home is, consent is not necessary to perform resuscitative hysterotomy. But yes, as sir said rightly, some team member has to go on and inform them what is happening inside. And once the debriefing is done, at the signing out is done, everybody goes and talks the same language that for some reason patient had cardiac arrest and so many things have been done. We don't know the prognosis. And post-resuscitation care in ICU is very, very important, so that therapeutic hypothermia and all those things are, I don't want to go beyond those things. But the bottom line is, BLS should include manual left uterine displacement. ACLS should include perimortem cesarean delivery, reset hysterectomy, and supradiaphragmatic venous access, and 4-minute code is what is important. You have to remember these things, which are very, very important, very essential. You just Google search AOA Task Force guidelines. They are Indian guidelines made relevant to our Indian scenario. You can read them and you can be on the same page. So I hope we are clear now. Okay. So,
hello, Dr. Gajjer sir, you have very rightly emphasized the need of presence of an anesthetist immediately, and that is why practice has started in Surat, in my knowledge, where the anesthetist is called in a normal delivery. He is present there to look after any adverse eventuality, and if the patient is fasting, the episiotomy will be taken under short GA.
So I think with this we conclude. There was one more scenario, but I think we have paucity of time. But we can continue in the panel discussion.
Please be seated. Please be seated for a while.
And sir, you have repeatedly stressed the need of fixing a captain of the ship.
Yeah.
In that context, I am reminded of one sentence in our favor, that a surgeon is a captain of a sailing ship, but an anesthetist is a captain of the
sinking
ship.
Yes.
Okay, in any case, thank you very much, sir.
Please be seated for a while.
Please.
See,
in any case,
it's a shared responsibility, and team is what is important. It is not that tu mein nahi chalega. We are all one. When it's a patient, crisis patient, we are all on the same page, and we are all on the same this thing.
Sir, I want to ask one question. Sir, when there is a ventricular tachycardia, patient was still moaning. So should we give anything, like I gave midazolam, which was a right decision or wrong?
So the thing is, at that moment of time, patient needed shock. It was a pulseless VT. And this patient was in the transition of becoming unconscious and this thing.
So no need. Anyway, thank you all of you. I know few, be seated here. Few questions are still left, but that we'll discuss in the panel. Yes.
For you, while you were doing that CPR, because of your height, your hands were like this.
Yes.
Doctors there. So you need a stool.
Hence, I told Dr. Tarun to give a demonstration of BLS, and he did very well actually.
Yes.
So the wrist, elbow, and shoulder should be in one straight line, and the hip should be the lumbar side should be a fulcrum.
Some sort of stool or something to stand. You have to stand up on a stool.
Actually, sir, the simulation is the first time going in this.
In any case, thank you very much, sir. Vaghela. I think we will have discussion later on. We are already running behind schedule. Thank you very much, Dr. Sunl Pandya, sir, for the exhaustive but excellent workshop, the first simulation-based workshop here with us. And we hope that in future also, you will come to us and enlighten us about the latest in obstetric anesthesia. I am very happy you cleared the need of, the necessity of perimortem cesarean section and when it should be done, and so many concepts were cleared. Now I request, as a token of our love and respect for Dr. Sunl Pandya, I request Dr. Vipul Kapadia, sir, to please felicitate sir with a memento. Now we are dispersing for a precisely 35 minutes lunch. We have to keep up with the time, and there is one request to visit the, please be seated for a while, please be seated for a while. There is one request to visit the stalls and encourage those people, and also because they are academic partners as well as they are our financial support.
Yes,
so
otherwise
please
we are
do
not
that.
getting another
One
workshop.
more thing, you are supposed to collect your money receipts and certificates from the stalls. So please do it so that in the end you do not miss it. So thank you all very much. You are a very
And,
good audience,
sir,
seated till very end.
we really
and
want to
meet
thank
at
you even
2:15. We meet at 2:15, please.
Mayur, who is the like man behind simulation workshop. Mayur, the big applause for Mayur.
Come forward.
Who is
Come forward.
man behind.
Come forward, Mayur.
Who is managing monitor. Who is making all surgeons and anesthesiologists and becoming panic. So thank you, Mayur.
He was creating the panic situations.
Yes. So thank you, Mayur.
Request.
And please maintain time. Please be cautious for your time management. Have your lunch.
And thanks for Dr. Sunil Pandya's management. We have saved all the 3 patients.